Hi, I'm Jordana Gilman. I'm an MD MPH student, and my friends who are going through the interview process for residency asked me to do a little healthcare overview. So this should be really quick and easy and hopefully not too biased. I'm going to go through some major issues in healthcare right now. It is October 2017, so this is what's really big. Spending is always really big. This whole season we've been talking about Affordable Care Act, Obamacare, whether we should improve it or repeal and replace it. Children's health insurance program, should we renew funding for that block grant? We're going to talk about the trend in payment structure, how it's been changing and how it should be in the future. The geographic maldistribution of providers, and contraception, which is always a hot button issue. In terms of spending, we spend $3.2 trillion on healthcare a year. This is money on the y-axis. Here's the United States, very high, and this is 2012. So by now, in 2017, we spend roughly $10K per person per year, and it says per person, but really we spend most of our money on a small percentage of people who are medically needy. And here's the US, much higher than everybody else. This is healthcare spending as percentage of gross domestic product. And it's just going up and up. So we spend more, but we get less. Other countries, their spending correlates with their healthy life expectancy at birth, but we don't. So that makes us a partially effective healthcare program. This slide you can peruse at your leisure. Keep in mind that to the right of the screen is best and to the left is worse. We do better on some things than others and generally not that great. Healthcare inequality is a huge problem. The graph over here shows percent with poor or fair health. So you don't want a big bar graph here. You want a small bar graph. And you can see that whites are doing better than blacks and Hispanics, and you do better if your family income is higher. And here we're seeing life expectancy based on your percentage of the federal poverty level. So if you are greater than 400% of the federal poverty level, you have a higher life expectancy. Okay, should we keep ACA or should we repeal and replace? Or should we use executive orders to dismantle it? Since the Congress hasn't been able to pass anything and get a repeal and replace bill going, President Trump has been using executive orders to alter many aspects of the Affordable Care Act. So if you think we should keep and improve it, you probably think that it's really great that 20 million people got coverage through the ACA, but some people still lack coverage and we need to keep it going to make sure we get those people covered. You probably like the individual mandate because you think it's necessary for risk pooling. That's how insurance works. You need healthy people and young people in the pool so that the cost of old sick people is offset. People everywhere love the stay on your parents' insurance till age 26 thing. That's very, very popular. And you also think that preventive services need a chance to work over time to save money. If you are in favor of repeal and replace, you might ascribe to this belief of moral hazard, which is that you need to make people pay a little bit for their health care so they don't abuse it. If you make it free, they will just access care when they don't need it, and it will be wasteful. You probably hate the individual mandate because it's against freedom of choice, and that is not very American. Also, you will notice that the marketplace rollout was far from seamless, and some places only have one option and thus prices are high. So the marketplace is this online database of different insurance companies that act as the companies that actually give you your insurance through the Affordable Care Act. It's not just one government system. It's all of these different marketplace systems in each state. And some places you can only have one option. So that's not good for prices. You'll also notice that the premiums actually went up for a lot of people. middle class people and upper class people. And that's because the youngest and the healthiest did not enroll at the rates that the designers of the Affordable Care Act anticipated. So they did not see those cost savings. Now let's talk about Medicaid expansion and non-expansion. This is a New York Times headline from Texas. Texas is a non-expansion state, so you have to earn less than $3,760 per year in Texas as a parent to be covered for insurance. Here we go. Here's Texas down in the bottom left corner. This shows you how much you need to make or not make in a Medicaid non-expansion state. So this is all a percentage of the federal poverty level. The federal poverty level was, you can see down here, $19,790 for a family of 3 and $11,670 for an individual. So if you're only making 23% of that in Missouri, you don't have a lot of money and you don't qualify for Medicaid in your state. You might be interested in this depiction because you're going to be doing your interviews all over the place, so you can check to see whether you're going to a state that expanded Medicaid or didn't expand Medicaid. The orange did not expand Medicaid at this time, and that's 19 states. And then 32 states adopted Medicaid expansion. Okay, what's the Children's Health Insurance Program? This is a block grant that covered about 9 million children. It's very popular amongst families. You can get it if you have 200% of the federal poverty level. So instead of Medicaid asking you to be very, very, very poor, this covers some people who are a little bit in the middle, and it at least ensures that they can get their kids covered. Yes, 9 million children, okay. In our country, we have always had a lower uninsurance rate for children because of CHIP. So this is from CHIP. Right now, the Congress has not renewed funding for the CHIP block grant. So it's a partnership between the states and the federal government, and the federal government has to put up that money every couple of years, and the federal government has decided not to renew that funding yet, and states are just running out the clock with whatever money they have. This is a map of how quickly states are going to run out of money. The very dark blue is October to December of this year. So kids who are covered by CHIP in those states are going to be SOL. CHIP is going to run out, and states are going to have to make reductions in those CHIP benefits. So states that used to be able to cover kids who lived in families that were 200% of the federal poverty level, they might have to go to kids who are just 100% of the federal poverty level, and then keep going down in order to save save insurance for the most vulnerable. Okay, let's talk about fee-for-service versus value-based payment. Currently, we have an emphasis on volume. You get paid if you do more stuff. It's fee-for-service. If you do a colonoscopy, you get paid for a colonoscopy. It's one patient, and you treat the patient. Then where we're going is this value-based payment utopia. And basically, it's going to be you get a sum of money for the number of people that you're serving, and then you have to figure out how to most effectively prevent disease in that population, so you get to keep the most of that money. And all of this emphasis is on prevention. It's on the population. Let's say Syracuse general surgeons get $10 million to prevent colon cancer in the population over the next 10 years. And then they have to figure out how to divide up their resources to accomplish that. Here's another comparison of the volume-based, which is fee-for-service, and the value-based, which is outcome-based. Pass a tube, get a payment, so do a colonoscopy and get paid, versus prevent colon cancer and keep your money. I I think that you can understand this. And so right now we are sort of in a transition period. We're trying to figure out how to do outcome-based medicine. We're collecting a lot of data on outcomes, but our payment is still pretty much based on fee-for-service. There are certain hospital episodes that are given a bundled payment. So let's say you go in to deliver a baby, the hospital is going to get, let's say $4,000 no matter what happens. So it's in your best interest to keep costs low. All right, we're going to be looking at alternative payment models. These are all things that are going to be happening as we move to outcomes-based and value-based payment. This is what we've got right now. This is still the fee-for-service. You've got your electronic health record. You've got some modifiers, and the physicians are reporting what they're doing. But in the future, everything is going to be integrated seamlessly. I don't actually know if that's true, but that's the goal. And our technology is going to be very much integrated with our care. It's not going to be just a paper chart, but on the computer. And there are going to be different ways to pay for payment, to pay for services. So accountable care organizations, let's go to that. Accountable care organizations are cost-sharing entities where a hospital typically will buy up a lot of different practices or ask practices in the community to join their ACO. And then because you're trying to prevent serious illness, the hospital will theoretically have less volume, but the hospital still has to make money, still has to keep their doors open. So they combine with outpatient services in the community that are doing the preventive work that get the money, and through cost sharing and cost saving, the hospitals get to keep their doors open, and theoretically people have healthier outcomes. So these ACOs are gaining traction. We have some ACOs in the region, and I'm sure you'll see that as you go through your residency interviews. Okay, let's talk about geographic maldistribution of doctors. I'm sure it's no surprise to you that doctors want to live in nice places. Typically that means cities, but sometimes it just means really nice rural areas. But not all states can offer that, and not all places in all states. So here, we'll talk about the role of immigration laws, and also I want to point out that a darker color here means there's more shortage, more people living in a shortage area. In terms of the immigration laws, as we make stricter immigration laws in this country, it's going to affect this distribution because a lot of foreign docs who come here for their residency opt to do several years of service in a underserved area. This waives their requirement to go back to their home country for a few years. So let's say you have an MBBS from Egypt and you just finished your residency and you don't want to go back to Egypt for whatever reason, you want to stay here. What you can do is you can go to Kentucky and work there for 3 years, and then your visa doesn't require you to return to Egypt and practice for several years before you come back here. So if we limit the number of immigrants who are coming in and doing residency here, then we're going to run into a greater problem with shortages of physicians. Okay, let's talk about contraception. Recently, on October 6th, the Trump administration issued a new executive order to undo part of the contraceptive mandate in the Affordable Care Act. So this grants employers religious and moral objections to providing contraceptive care. So if you're an employer, regardless of the size of your company, you can, I guess any nonprofit or closely held profit employer. Closely held is sort of a legal term. The Hobby Lobby case, you'll remember, was a closely held company. But there's a lot in here. Employer or college, university with a student health plan. So if you are a college or university with a religious slant, you don't have to include contraceptive coverage in your student health plan. If you're an employer with moral objections to contraception, you don't have to include coverage for that in your plan. So that could result in some people not having contraceptive coverage and increasing the out-of-pocket cost for contraception. Here's a graph of what women have been paying, or anyone who needs contraception, what people have been paying out of pocket since the Affordable Care Act took place. The contraceptive provision took effect here. Then this is 2015. And then if the graph continued for 2017, we would probably see a little uptick because of this new executive order. All right, now I have 10 slides that go through pro and con of a few different issues, and it's mostly in the lens of the Affordable Care Act, and I'm going to let you peruse them as you would like. Basically, if you like the Affordable Care Act, you think it costs less and it saves money, and if you don't like the Affordable Care Act, you think it's expensive and it doesn't save money. If you like the Affordable Care Act, you think it's going to decrease the federal deficit. If you don't like it, you think it's going to increase the federal deficit. Same thing with Medicare, Medicaid. You can read that if you would like. Pause the video. Here we're talking about the primary care physician shortage, similar to the geographic maldistribution of doctors. The people who like the Affordable Care Act think that the Affordable Care Act is going to result in more primary care visits, which is a good thing. And we think that if you don't like it, we think that the primary care shortage will be this many physicians by 2025. Okay. Independent Payment Advisory Board. This is another aspect of Medicare spending in the Affordable Care Act, and you can read that. Abortion funding, if you like the Affordable Care Act, you think that it is completely in line with the Hyde Amendment, saying that federal funds will never be used for abortion services. If you don't like the Affordable Care Act, you think that it is in violation of the Hyde Amendment and that the ACA is actually basically providing a backdoor for federal funds to be used for abortions. If you like the Affordable Care Act, you think it's great that people are going to be able to get preventive measures before they get to an emergency status. So they can go see their primary care doctor because now they have insurance and they can get things taken care of before it becomes totally emergent. And if you don't like the Affordable Care Act, you think that it's going to just make emergency visits skyrocket because now you have insurance and you've been waiting so long for whatever your health problem was, and now you go to the emergency room and just dump on them. So this is actually from the American College of Emergency Physicians. 47% of emergency physicians will indicate slight increases, while 28% report significant increases in the number of emergency patients. And here's physician views. Do you like it? Do you not like it? Do you think it's helping? Do you not think it's helping? And impact on business. Has the Affordable Care Act produced lower costs or not? This is what I have for you. If you have questions, I'm very happy to answer them to the best of my ability and with as little bias as possible. I hope you enjoyed it, and thank you.